Well, welcome everybody. My name is Ray Kim. I'm from the Steadman Clinic up in Vail, Colorado. Have many of you spent time up in Vail? I know. Chief, yep. Anybody else? Yep. Little skiing, little snowboarding?
Little repair work.
Little repair work? Okay. Yep. Did Becky send you up that way?
He was the doctor of it all anyway.
Oh, gotcha. Well, it's a privilege to be down here. And as we were walking in, we couldn't help but to notice the 9/11 memorial. And so first of all, just want to say we appreciate all of your service. What you all do is incredible. And it's great to be able to try to give back to you all. And so it's an honor and privilege for us to be here. So I'm here with a team. We have Leah Dvorkin or Dawson? Either one. Leah Dawson, Tim Ryan, and Vicki Martin. And I think you probably feel the same way, but if Becky tells you to do something, you do it, right? And so we're up here because Becky gave us a kind invite to share a little bit about hip and knee arthritis, hip and knee pain, and how to treat it, and what's new in 2025. So I'm going to have Leah come on up here. I'm basically just pressing the buttons for Leah.
I don't know about that.
But we're going to kind of tag team this.
We'll do it together.
So how many of you have had previous knee or hip injuries or issues? So very common. So we see it every day. In your line of work, I'm sure you see this quite often too. Whether it's wear and tear or injuries, sometimes this could lead to problems which we always try to treat non-surgically, but sometimes it can't be fixed non-operatively and it ends up being surgical. So let's kind of jump into things. Just a little background. So I did my training at the Mayo Clinic up in Rochester, Minnesota, spent 5 cold winters there. Then went to New York City where I did my fellowship at Insall Scott Kelly. And then I actually took my first job right here in Denver in 2006. Spent 11 years down here in Denver. We specialized in joint replacements, knee and hip replacements. That's where I met Vicki. Vicki, you've been with me for how many years now?
In June it'll be 12.
12 years. Vicki's born and raised Colorado gal, diehard Broncos fan. Started her career in Denver, and then when we moved up to Vail, Vicki came along. That was over 8 years ago now, right? And shortly thereafter, that's where we met Becky, who, when did you start there? That was like 6 years ago, 7 years ago?
No, it's probably like 4 or 5.
4 or 5?
19, 20, I think.
Yep. But Becky, being the city mouse that she is, came back down the hill. But we had a busy practice down here in Denver. At our peak here in Denver, we did 800 joints a year. We did have patients that would stay in the hospital with their knee and hip replacements. Our average length of stay got down to about 1.6 days. But then we were asked to come up the hill, and Dr. Steadman, he is, I would say, the godfather of ACL reconstruction. Also specialized a lot of his research in repairing cartilage. Had a technique developed where they could do what's called microfracture, put little holes in the bone to create some bleeding to help create some scar tissue to patch those potholes in the cartilage. And they've done outpatient surgery for decades and decades. Dr. Steadman was in Tahoe and was brought out to Vail in 1990 where he began this practice. So very well versed in outpatient surgery. And so we got the call in 2016, right? Asked to come up the hill and to partner with the Steadman Clinic and bring joint replacements out to a center where they did a lot of outpatient surgery. So they asked us to start a new joint program in Colorado, and people talk about a new joint program and it has a little different connotation. And even back then in 2016, it had a lot of different connotation. You know, we know the history of marijuana in Colorado with medical marijuana, recreational use, and even some of our patients have had a little bit of fun with starting a joint program in Colorado. But we've gotten to the point where Now we do a high volume of joint replacements up in Vail, up at 8,000 feet. And the vast majority of these are outpatient. About 98% of our joints are outpatient. And in 2023, we did over 1,000 knee and hip replacements. So we're going to kind of shift a little bit and just talk about what is arthritis. We're going to talk about treatment options, and then we'll talk about what's new in the world of joint replacements. So let's start with the basics here. So what is arthritis? Does anybody know what arthritis is? Anybody want to venture to take a guess? Anybody?
Come on, guys.
Don't be shy. It's not a test. I know you guys are used to a lot of tests in the fire department. This is not a test. Even though you got a chief sitting back there, nobody's...
Doesn't know what it is either. It does hurt.
It does hurt? Okay, does anybody know does anybody appreciate artwork? Does anybody know what these are? Little sculptures. Wishbones, yeah. So these are sculptures made of chicken bones, okay? And if you look at the end of a chicken bone, what do you see? You see, what's that? Shiny, yeah. What is that shiny stuff? Anybody know what that is? Articular cartilage. Yep, hyaline cartilage. So what is that? What's the purpose of that shiny stuff?
Protection and shock absorption.
Exactly. So it protects the ends of the bones. It's kind of squishy. So this cartilage is squishy. It's about 70% water. So it's not like, hard like a table, but it's kind of squishy. It's got a little give. And that's what allows the joint to move very smoothly. Okay, so in a normal joint, you don't hear that grinding and creaking. It moves very smoothly. But what happens if you get injuries or damage to it? Starts to break down. It's no longer smooth and shiny. It becomes rough. Has anybody seen like arthroscopic pictures where there's, it sounds like you've had some arthroscopic work. So that white shiny surface is no longer perfectly shiny. You get little potholes, and sometimes it becomes even bone on bone. And that's where it becomes very, very painful. And it grinds, and sometimes it gets caught and stuck and become very problematic. So what are the symptoms of arthritis?
Pain,
Pain,
swelling.
swelling,
Limited mobility.
limited mobility. Okay. Leah, you see all these patients that come into the clinic, and they're not necessarily ready for surgery, but what are these patients presenting like?
Yeah, so sometimes it's just simple things, right? Things day to day, difficulty going up and down their stairs, or if they're seated in a car for a long period of time, long road trip, and they go to get up and like, oh, kind of that startup pain, long flights, things like that. For some of our hip patients, simple activities like putting on their shoes and socks or getting down to cut their toenails. So it's not necessarily always the big activities that are causing issues, it's sometimes the simple things.
Yeah, so a lot of daily activity problems. And then a lot of our patients, we live in a very active community. They're skiers, hikers, cyclists, runners. So it's not just the daily activities, but they're frustrated because they can't do the recreational things that we all love to do. So these patients come in and they're complaining of their knee pain or hip pain. How do we work them up? How do we diagnose them?
Yeah, so it's really important for us to really get to know our patients, right? What do they like to do? What are the things that bring them joy every day? And where are their ailments affecting that? But we do start, so a really good history, a really good physical exam. I would say, 80% of our diagnosis can be made just off that. And then for us, we like to lean right into some x-rays. Just some plain films can honestly give us the biggest story. Higher level imaging like MRI and CT sometimes needed, but typically for us, just a plain x-ray is that, along with their physical exam and history, is enough.
Mm-hmm. Mm-hmm. And what are the treatment options? So let's talk about non-surgical treatment. So when you come into the doctor's office, nobody's rushing you off to surgery. They're not saying, hey, we got a spot open this afternoon. We're gonna replace your knee or replace your hip. What are the non-surgical things that you think can be done for these things? Injections. Yep. Therapy. Yep. So Becky's often managing a lot of these non-operative treatments, right? And there's a lot of different flavors of injections. Leah, what kind of, oh, I'm sorry?
Like offloaders?
Yes, yes. Yeah, unloader braces, offloader braces. So taking the force, and sometimes there's one side of the knee that's very arthritic or painful, and you're trying to shift, that brace can offload that area of the knee and transfer the forces to the other side of the knee that's still in good shape. Yeah.
Sometimes even just some simple over-the-counter anti-inflammatories. People don't think about that because it becomes part of your everyday, but those are some great alternatives that are non-surgical. Help decrease the inflammation. So when you have the arthritis in the knee, it's actually creating this inflammatory response. So it's mechanically not going to change anything by taking these anti-inflammatories, your Motrin, your Advil, your Aleve. But if you can alleviate some of the inflammation that's there, it decreases the pain and ultimately can buy people some time.
So people always ask, what's the best anti-inflammatory medication out there? And we have Advil, we have Aleve, we have prescription anti-inflammatory medications. What do you think is the best anti-inflammatory medication out there? Ice is actually great. Yeah, that's a great answer. In terms of medications, what do you think is the best one out there? Ibuprofen? Whatever. So actually, that's so true because everybody is different. Everybody's physiology is different. So for me personally, Aleve works amazingly well. Some of those prescription ones, I've tried all of them. For me, don't work as well as Aleve does. Do you have a favorite one?
Celebrex.
Celebrex?
Prescription. Yeah.
Yep. But does anybody else have a favorite anti-inflammatory medication? Celebrex? Yeah. Celebrex is a great one, but again, I think what may work for one person may not necessarily work as well for someone else. So sometimes we try some, over-the-counter stuff. Sometimes we add some prescription ones. Some of the advantages of the prescription ones are they can last a little bit longer. So Advil's great, but it's about 4 to 6 hours, maybe a little bit longer. Some of these prescription ones can last for 24 hours. So you just take it once a day, you can take it with breakfast, and it gives you the whole full day of relief. Injection options. People always ask you about injections.
Yeah.
So when they come into the office and they're asking for injection, Leah does all the injections. I don't like needles. So Leah's doing all the injections.
Yeah.
But
So there's a lot of great options from an injection route. So I think the ones that people most commonly ask for or hear about are steroid injections. So it's a small amount of an anti-inflammatory, typically mixed with a little bit of a numbing medicine directly into the joint. Again, similar to the over-the-counter oral anti-inflammatories, mechanically and structurally, we're not changing anything in the knee, right? So we can't get rid of the arthritis by taking these anti-inflammatories, whether it's oral or into the knee. But we can, again, decrease the inflammation, which then improves pain and ability. So we have steroid injection options. We also have hyaluronic acid injection. So people maybe say, oh, that rooster cone, that chicken juice, kind of is the lingo around. And sometimes we'll even couple that with a little bit of a steroid or an anti-inflammatory injection as well. And then depending upon specific arthritis patterns, we can do stem cell or some of the biologic injections. Kind of depends on the knee and how arthritic it is, but some patients can get some great benefit from that as well.
Actually, Becky probably has the most experience with some of the biologics out of everybody here. We see the patients long after all the injections aren't working so well, but some of the ones that have mild arthritis, sometimes those biologics actually can work pretty well, wouldn't you say?
Yeah, PRP, BMAC was like a little bit during surgery-wise, but PRP, people had good results.
Yeah. Anybody here have a PRP injection before? Basically, they take some blood from your arm, they spin it down, they get rid of the bad stuff, keep the good stuff, and put that injection back into your knee, your hip, your shoulder, wherever they're having issues. So let's say all those things are not working anymore. Then we get to the conversation of surgical interventions. So there's a few different options, and it kind of depends on what the actual issue is, but it could be as minor as what we call an arthroscopic procedure. So that's where through a couple little poke holes, you can look into the joint with a camera. You have small little tools to nibble out torn pieces or loose pieces, or even repair some of the meniscus. There's what we call osteotomies. So sometimes people have some alignment issues. They could be, let's say, built very knock-kneed or very bowed. And by having this malalignment, it's almost like your wheels being malaligned on your car. So if your wheels are malaligned, what does that do to your tires? wears them out faster, right? So by fixing the alignment of your wheel, you will help the tire wear less quickly. So the same thing can happen in a joint, where if it's out of alignment, and typically these are younger patients, you know, if you wait decades and decades, sometimes it's too late. The cartilage is already worn, the tread on the tires is already gone. But if you can catch it early, sometimes you can change the alignment or correct the alignment so that the joint can last longer. So that's called an osteotomy. That's actually, in Becky's old practice, that's what they did a lot of and did them very well. The definitive treatment is what we call joint replacement. So that's where the cartilage is completely worn. So you've worn the tread on the tires, and there's nothing you can do to repair that, so you replace the joint. So does anybody know much about joint replacements? Yes, question.
If you were to do a cortisone injection, if you're trying to kind of buy time, is there a period of time you like to, and then they don't end up improving, that you need to wait after an injection before you would consider surgery?
Yeah, there is. So there's some recent data in the past few years where if you do an injection and then you jump right into a joint replacement, there's a slightly higher risk of infection. So the conservative figure is 12 weeks from the time you had injection to the time you have a replacement. And at 6 weeks, that's really the minimum amount of time that we wait. So 6 weeks we like to wait, if possible 12. After that, the risk goes down to baseline. Yes?
Oh, go ahead.
So if you have an injection, get a cortisone injection.
Yeah.
Can that accelerate the deterioration of the cartilage?
So great question. So in super high doses, there's some thought that the cortisone can break down some of the local tissues. Cortisone is not good in things like certain tendons, like the patellar tendon, the Achilles tendon. Those are places you never want to put cortisone because that can increase the risk of tendon rupture. In a big joint, the doses we're using are relatively small. So we say a couple injections in a given joint in a given year is okay. And again, the doses we're using are relatively small for these larger joints. Yeah. You had a question?
Is that like that wait time for the increased infection risk the same for like an HA or like a biologics injection, or is there any time if you do something like that you would wait?
So we think it's cortisone or HA or even one of these biologic inject like PRP.
Yeah.
We still recommend ideally waiting that 12 weeks. Yep. So it's funny, people think it's introducing bacteria into the joint, which certainly can happen, but there's what we call the microbiome. So the joint itself is an environment where things live in harmony, even, just like your gut. You have good bacteria and bad bacteria, and if something upsets it, then you end up with GI upset. Well, the same thing can happen in a joint, where if you introduce something into the joint, it can upset the biologic environment, and that's what can increase the infection risk. So it's not necessarily that you're introducing bacteria, but you're upsetting the environment of the joint itself. Yes, Chief.
I just had a quick question post-surgery. So prior to surgery, I was taking celecoxib, and then I took it for, years. And then the arthritic pain started to become worse and worse. And so the doc was like, well, you could take 2 of those if you'd like every day.
Sure.
So I did that for, about a week, and that was not good for the rest of my body.
Mm-hmm.
What's really cool is post-surgery, I haven't taken them anymore because the pain, the actual knee pain's gone. Now, the muscle and joint, or not joint, but the tendon, ligament, maybe pain around the knee now. Mm-hmm. Once in a while is a little problematic, but nothing like before I had my replacements. Is there some efficacy if as rehab starts to ramp up, or I start to do my own rehab that looks a lot more like, being on a elliptical for an hour, or doing things Meg doesn't want me to do? Would there be any efficacy to occasionally taking celecoxib if?
Absolutely. So even if you replace a joint, so you're getting rid of the arthritic surfaces where that bone pain is gone, you can still irritate the structures around the knee joint itself. So that's where those anti-inflammatory medications can still be helpful even with a replaced joint. So that's okay to do.
It is okay.
Yep.
Okay.
Yep. So who knows what happens in a joint replacement? Okay. So,
I haven't watched the video. I've been.
and don't worry, we're not going to show any gruesome videos or anything with a lot of blood. Becky was hoping we're going to see some, some surgical footage, but all we're doing is we're removing the arthritic surfaces and replacing them with artificial materials. So in a knee, typically it's cobalt chrome and polyethylene. Polyethylene is basically surgical grade plastic, which acts like your cartilage or your meniscus. Okay, so we're just removing a thin layer. People think, oh, you're whacking out my knee from here to here, putting a big chunk of metal. That's not actually the case. We're just removing a thin layer. It's actually less than a centimeter, and we're placing a new surface on the ends of the bones. And then on a hip, a little bit of a different operation on the socket side. The ball and socket is bone on bone, so the cartilage is gone. So on the socket side, we clean out the cartilage and the arthritic bone on the inside. There's a new shell, a new cup that's placed into the socket. And then there's a polyethylene liner that snaps into the titanium shell. And then on the femoral side, on the thigh bone side, there's a stem, a titanium stem that sits in the top of the femur, the thigh bone. And then there's a ceramic ball that becomes your new ball, and that's what articulates with your socket. It becomes your new ball and socket. Any questions there? Piece of cake. It's just replacing parts.
In your knee version, what do you do with the ligaments? What replaces it? You have no ACL or PCL then?
Great question. So the ACL and PCL are typically degenerated in an arthritic knee, and we don't need those. So the stability is built into the implant. So the implant's designed so that it has something called a cam and post. So that creates the stability from anterior to posterior, from front to back. The ligaments on the sides, the MCL on the inside and the LCL on the outside, we keep those. So those are still functional in a replaced knee. There's some rare circumstances where people have an arthritic knee with a torn or ruptured MCL or LCL, and that's where I'll grab one of my sports partners like Dr. Vidal, and we'll do these combined procedures where we replace the arthritic knee, but the ligament is also reconstructed at the same time. Yes, question?
So like a knee versus a hip, so like the knee, would you cement most of the time for the placement and the healing? Versus
Yeah.
the hip, how would you do those?
So in the knee world, we do have cemented and cementless knee options. If you look at all the data for, and knee replacements have been done since 1973. I don't think any of you were born before 1970. Well, okay, maybe Chief. I didn't want to call Chief out, but but knee replacements have been done since 1973. Okay, and if you look at cementless and cemented knees still win in terms of long-term survivorship. Now, hips are a little bit different. So we've got great data now for decades that show that cementless hips have done beautifully, and those outcomes actually have surpassed the cemented hips. And the cementless hips is where the bone will actually grow right onto that titanium. It takes about 12 weeks for that to happen. So that titanium essentially becomes part of your own body.
How does that change your rehab if it's, say, a hip that's cemented versus not cemented? Is that...
So typically we slow patients down for the first 6 to 12 weeks. So at 6 weeks, we let them start doing some light recreational activities, get on a bike, longer walks. It's 12 weeks before they're doing full activities, things like, skiing, tennis, aggressive hiking, because we want that bone to knit to the titanium.
Not cemented? Is that what you're saying? Is the cemented version or non-cemented?
In the non-cemented.
Okay.
In the cementless hips. Yeah, great questions. Any other questions about the surgery piece?
How often do you address the patella with total knees?
So most of the time we prefer to save the patella. So the patella is an important bone. That's your kneecap. It's not a big bone. It's relatively small compared to the rest of your anatomy. So a couple times a year, we'll see some patients that take a tumble down the hill and actually fracture their patella, fracture their kneecap. If we've resurfaced the back of their kneecap, then the amount of real estate they have is very, very tiny. There's not a lot of bone left for the trauma doctors to pieced together with some screws and wires. So our preference is to try to preserve the kneecap if it's still in good shape. Now, if it's really, really arthritic and eroded, sometimes we put a button on the back of the kneecap. But we like to preserve it as often as possible. So let's talk about what's new in the world of joint replacements. Have you heard about what's the latest and greatest? There's always things that come out. There's, new implants, there's new instruments, there's new techniques, there's all kinds of gadgets and widgets. Anybody here see any commercials or anything about new stuff that comes out? We have a lot of patients will come into the office and they'll bring in some articles and be like, Leah, have you ever heard of this or that?
And sometimes I haven't yet. I mean, it's like fresh off the news,
But let's talk about some of these new technologies and what's new. So we have very, very robust implants. So back in the older days, we had these implants that did pretty well, but they would say, well, in about 10 to 15 years, we've got to swap out some parts because that polyethylene, the surgical grade plastic, would wear out, okay? And then you got to go back in and swap out some parts. But in this day and age, we have very, very robust implants, and we expect multiple decades out of these implants. So it's not just 10 to 15 years, but we expect decades and decades.
Are you saying like 20, 30 years now out of?
There's
We have
actually
a lot
some.
of patients who are like, well, I don't want to, they have terrible arthritis, but they don't want to have a replacement because they're worried, oh, it's only going to last 15 years.
Yeah, so our implants are much better, but we still have that conversation where, with our, so I've got 6 patients in their 20s that we've done knee replacements on, 6 patients in their 20s that we've done hip replacements on. So in these scenarios, we do like to try to get them a little further along. So,
somebody in their 50s should not be afraid to go have their joint replaced if it's.
We have a ton of patients in their 50s. We have a lot in their 40s and even younger. So yes, we do try to get them by with either non-surgical treatments or some joint preservation operations. But sometimes everything's been done, and really the last resort is joint replacement. So it becomes a quality of life question. Like, if you're in your 40s, 30s, or even younger, do you choose to get your joint replaced, knowing that there's a possibility that you could live, till you're 80 or 90 and you might need a second procedure, or do you try to gut it out and live with the pain? So it's a very subjective decision-making process, and everybody's got their own threshold for when they decide to get a new joint. So we have some fancier instruments. So we've been using something called computer navigation. We've got other technologies. What's on the next slide there, Leah? Oh, I'm gonna put Tim on the spot. This is a cool thing that has come out relatively recently in the past year. Maybe just press.
Oh boy. See, I'm not good with tech. Please.
Maybe just try pressing it. Let's see if this works. Oh, there we go. This is what we call augmented reality. So you've seen the fighter pilots. They wear these cool helmets with the screens. The camera's right on their helmet. And we've got a very similar device where it's all built into our surgical spacesuits. So we have Tim, who actually works for what's called Innovis, the company. Yeah. Tim, any comments on, this is your 15 seconds here.
It's as cool as it looks in the video.
So there's always new technologies coming out, and people say, well, where are we at in 2025? Knee replacements and hip replacements are in a very good spot in 2025, but of course, if you wait 5 years, 10 years, you're going to have improvements in technology. So the question is, do you wait a little bit longer? And really, it's a matter of how much can people stand the pain and stand putting up with their dysfunction. So really the biggest thing I would say that has been game-changing in the past decade has been outpatient joint replacements. So when I was training at the Mayo Clinic, we would keep patients in the hospital for 5 days, and we'd have to round on them. You know, you change their dressings. You know, they're on these IV narcotic pain pumps, and they press this button, and they're, you know, having all these issues. The pain control was very poor. So in more recent times, we've been able to do this as an outpatient. So instead of 5 days, patients are in the surgery center or in the hospital for about 5 hours. So they're literally going home same day, walking, putting full weight, doing stairs right away. So a very different recovery from where it was even 8 years ago. And we've published on this. This is just a paper that we put out just a few years ago talking about how this has become the new reality. So most centers in the country are still doing what we call inpatient joint replacements. About 98% of our patients are going home same day. So if you look at the percentages of knee and hip replacements being done as an outpatient, it's, you know, back in 2012 when it wasn't known very well, it was a very, very small percentage. And now in our practice, we're doing about 98% outpatient surgery. So we always say joint replacements is a team sport. Vicky is our captain of the team. If you guys follow Warren Buffett, one of his principles is you gotta hire well. And Vicky, I want to put you on the spot here. You want to tell them about our team? It's a pretty big team.
It is a big team, yeah. So we have 4 PAs, a nurse, a new patient coordinator. We have Dr. Dave Coopersmith, who clears all of our patients. We have Tim, our rep, and then anesthesia obviously plays a very good part in doing our outpatient joints. So big team to take care of a lot of people and make sure that our patients feel like they're the only patient, right? When you do 1,000 a year, it's hard to make each patient feel like an individual. So we have such a large team, so everybody feels like they're the only person we have to take care of that day. So I think that's worked really well for us.
In your line of work, you know how much having a team is important. You're not the only one on the front line. You've got a squad of colleagues, people that work with you, work behind you, and it's so important to have a team that works together as a cohesive unit to be able to make sure that your knee or your hip has the best possible outcome. So it starts with patient selection. So we have an internist, a dedicated internist, Dr. David Coopersmith, who specializes in perioperative medicine. So what that means is it's everything medically related to your knee or your hip before, during, and after surgery. So we have a lot of patients that are healthy, but a lot of patients come in that aren't so healthy and may not have even known about their health issues. So sometimes people come in and they see Dr. Coopersmith, he gets a bunch of lab tests, and they may have diabetes and have never seen someone for their diabetes, or may have, you know, a blocked heart artery and never realized it. Or what are some of the other medical issues that have
Kind of
come
some
up?
uncontrolled thyroid issues.
Yeah.
It's often found just incidentally. And I think a big thing to remember too, I think patients feel like they might be disqualified for whatever reason. They saw their primary care and they said, you know, you're not a great candidate. But with the collaboration with Dr. Coopersmith, we can really optimize patients. So just because you have a diagnosis doesn't disqualify you necessarily from surgery with us. We can work cohesively as a team with their primary care providers, with the patient, with us, to get people ready for surgery, which I think is a nice benefit for some folks who hear no, and we can say, well, yes, just maybe give us a few months to get you there.
Talk about some of the issues like BMI issues or smoking. How are we managing all that?
So this is all kind of part of this preoperative selection. So we do know there are risk factors with surgery. Surgery is not 100% and not without risk alone. So if we can eliminate some of those risk factors to get people the ultimate successful joint, that's our goal. So tobacco can increase risk of infection and post-surgical complication. Elevated BMIs greater than 40 have been well documented to increase post-op complication. History of DVT, PE, any type of clotting factors as well, all get taken into account. We also like to see for our diabetics well-controlled glucose. So looking for A1Cs, ideally less than 7. And again, these are factors that we can help patients get to a goal that not only are great for surgery, but great for their life, right? So we're looking to get people back to doing what they want to do, and hopefully for a long period of time.
Any questions there about the Yes?
Do you do surgery on heavy smokers, or do you like not?
We make them stop for at least 6 weeks prior to their surgery. So sometimes they'll come in, you can smell the tobacco on their clothes. And Vicky's got a very sensitive smell. She's like, I think that patient was a smoker. Did you ask about smoking? And so if they are a smoker, and it's also tobacco because nicotine is a vasoconstrictor. It constricts your blood supply, your blood vessels. So we worry about the circulation to the area that's healing, your knee or your hip. Because if you don't have good circulation, the wound can break down, and that can be a risk factor for infection.
So do you talk to patients about like smokeless nicotine? Like you guys, is that part of your?
Yeah. Any kind of nicotine product.
I have to say it's one of the toughest, but also one of the most rewarding conversations to have with our tobacco using patients, because a lot of times we're the reason that they quit, and then they stay off nicotine tobacco for the rest of their life. So when they're that excited and ready for a joint replacement, they're willing, and it's the single best thing you can do for your health, right? We all know that working in the field. So to be able to actually sit down and have that conversation with, which maybe providers previously don't take the time to do, it's a wonderful reason to quit, right?
Yeah, healthcare is a long game. So it's not, yes, it is about their knee or their hip, but it's also about their entire health for years and years to come. So we want to try to have an impact long term on all these aspects of their health, and that's why Dr. David Coopersmith is a critical member of the team. All the pre-op education, I'll let you talk about the pre-op education.
Yeah, so basically expectations, right? If we can set what the expectation to be both before, during, and after surgery can be right up front, we can really prepare both the patient and their caregivers for success. So we talk a lot about day of surgery, timing that they're with us, how to prepare their home. So this is actually all given in an audio clip prior to their surgery, so they can press pause, listen to it again with their caregivers. Day of surgery, they're checking in anywhere from typically about 2 to 4 hours prior to the procedure. Dr. Kim's surgical time is about an hour, and then in the recovery room, again, 2 to 4 hours, and then planning to go home that same day. Mm-hmm. So all of this is kind of set up ahead of time for them, and then in that part, we start talking about post-op pain management and medications. Mm-hmm.
So anesthesia, people think you're under like this deep sleep. So actually, it's what we call a short-acting spinal anesthetic. So it's an injection in the back. You're numb from the waist down for about an hour and a half. When that wears off, the surgery is already done, and you're up and walking, doing stairs right after surgery. So you get a little cocktail in your IV. So it's similar to if you had a colonoscopy. So you're taking a light nap. The patients can be as awake or as sleepy as they want to be. Our tools are pretty loud, so most patients don't like to hear the noises, so they like to be taking a light nap. But they're not put out in a deep sleep. Mm-hmm.
And then in the recovery room, they're actually given so Dr. Kim referred to the pain pump that they were given in the hospital, so there's actually a portable version of that. So we call it an adductor canal catheter, and it gives them some numbing medicine that will last about 3 to 4 days afterwards. They can bolus it. It doesn't wipe out their motor function, so that's how they're still able to get up, walk, do their physical therapy right away, but still have some adequate pain control as well, and then decrease overall narcotic intake afterwards.
Here's our surgical workflow. This is a day in our operating room. So we have operating days and we have clinic days. In our operating days, we like a prompt start. 6:30 in the morning is our first incision. And we have 2 rooms. We'll go back and forth between the 2 rooms. We have a very large team. We have people that are the nurses and what we call surgical scrub techs. They're positioned in each room, and we go back and forth between the 2 rooms every 45 minutes. And a full day for us will be 14 joints, 14 knees or hips.
Do you have a preference of knees versus hips first, or do you just alternate rooms?
We like to start with knees because from an equipment standpoint, the hips have we use this big like live x-ray machine for our hips, so it takes a little longer for the setup. So we typically start with our knees and then we move into our hips. You want to talk about PT?
Yeah.
Leah? Yep.
So I think The single best thing is getting our patients up and moving, right? And that's how we can get everyone home and into the comforts of their living spaces. So physical therapy right away for our knee patients. So full weight bearing, crutches or walker just for balance and support. And then they'll start range of motion exercises right away as well. So for the first 6 weeks, the focus is really on getting that swelling down and working on range of motion. At the 6 week mark, Dr. Kim mentioned, we'll slowly start ramping up some stationary biking, transition to outdoor biking, some gentle hiking. Our golfers can start some chipping and putting, and then full recreational activities at the 3-month mark. The big difference with our hips, there's actually no formal physical therapy. Really the mainstay exercise is walking. So for, as you can imagine, folks like yourselves, that seems wild, right? Just walking, I just had this hip replacement. Truly, walking can actually stimulate some of that healing to occur, getting that bone to knit onto the implant, letting all the swelling kind of come down. At the 6-week mark, similar ramp up. So some gentle biking, gentle hiking, and then full sports and recreational activities at 3 months. So that's the main difference between knees and hips, but we want you up, we want you walking.
So this is always the big question. We have this every time a patient comes into the office. Well, how do I know it's the right time to have a knee replacement or hip replacement? And we're never twisting arms, because the honest truth is it doesn't make it any harder for us to replace that knee or hip or for you to recover from it if you put it off. So sometimes people come in, we say, you know, you can put it off for a month, you can put it off for a year, you can put it off for 10 years. It's never a medical emergency. Now, you all are used to taking care of emergencies. Hopefully nothing like this, or maybe you have. I'm sure you've seen some pretty gruesome injuries, but there are things in orthopedics that are emergencies. Joint replacement is not one of them. So there's never an emergent need to get that joint done right away. I know, like, there's work pressures, there's, you know, social pressures, you know, your families are telling you gotta, you know, get some, but in fairness to you, it's your knee or your hip. So you are the one that's gonna ultimately make that decision. So the factors that we really base it on, or that you should base it on, is number one, the pain. And everybody's pain threshold is different. Sometimes you see patients that don't have much pain and others are really struggling. They come into the office and they know that they want their joint replaced. Your quality of life, your function. So again, sometimes it's, you know, whether or not you can ski on the mountain, and for other people it's, well, I gotta get something done because I gotta get back to work. So I always say it's like getting married. Anybody married here? Okay. So how did you know it was time? Well, you just kind of knew. So it's a very subjective, personal decision-making process. Hopefully you're not like this guy here that's saying, help me when he gets to the altar. But ultimately it becomes very, very clear when that timing is right.